Welcome to Policy Exchange's latest Agenda podcast. Today we have with us Robert Eade, Head of Health and Social Care at Policy Exchange, and Dr. Sean Phillips. They are the co-authors of the report at your service. Robert, what the COVID crisis, the COVID period, what have people's experience of their GP services been during the last 2 years? Have people's expectations gone down, or what's been happening?
Thanks, Michael. I mean, plainly, the last 2 years have been exceptionally challenging for general practice. At the start of the pandemic, GP surgeries were effectively told to close their doors, and that meant that the population stayed away. You did see a big embrace of digital and telephone technology. We went from roughly 1 in 10 interactions with the GP being over the phone to almost 80% in just a few months, which has been very positive, but it's also caused issues. And you see that now with regular newspaper articles highlighting that people want to see their GP in person and aren't able to do so. You can if you look at the latest GP satisfaction data, the public has started to lose faith in general practice. And it also cuts the other way. GPs are increasingly reporting burnout. We're seeing more GPs leave the profession. So in the words of one GP that we spoke to for this research, something has to change. We cannot continue with the current system.
One of the main calls in the report is for an increase in salaried GPs and a reduction in the current partnerships and independent practitioners, and that you actually call for the fading out of independent contractors by 2030. Why do you think the salaried GP system would be better?
The phase out is already happening. We've seen a decline in the number of partners year on year working in the NHS. It's due to a number of factors. Younger trainees, newly qualified GPs, don't necessarily want to be a partner. The onerous nature of running your own business brings with it certain risks and liabilities that they don't want in their careers. They want portfolio careers where they might combine clinical research roles with doing some locum work, with working in different settings. GPs want to increasingly work in hospitals and vice versa. And the partnership model gives you flexibility in some areas, but it also locks you into running a business. Our proposal is not that we should move everyone onto what we think of as a salaried GP at the moment. Instead, it's saying we can mimic the best bits of being a GP partner, that sense of autonomy, that sense of independence, that sense of leadership over a team, but as part of a new primary care structure where a GP will sit at the top of that pyramid, but they'll be assisted by nurses, by other specialisms within general practice to better allocate and meet the needs of their local population.
The report at your service had the foreword by the Secretary of State, Sajid Javid, and you're obviously trying to get your proposals adopted and hope they'll be adopted by a Conservative government. Traditionally, Conservative governments have been seen as being very keen on small businesses, enterprise. Isn't this in some ways a move away from that? Isn't in some ways what you're proposing amounts to the nationalisation of GP services?
I think we would challenge the idea that this is a nationalisation. The political question is, do you accept the decline, or do you support an orderly transition to a positive alternative? We do not see a diminished role for the independent sector in future primary care. If anything, we would say that trying to move towards a more of a scaled model of general practice where different surgeries partner together is actually advantageous for businesses who want to work with the NHS. If you have a proven innovation, you can sell to a group of general practitioners who can then distribute that particular good. It could be an interesting diagnostic. We got very used to doing diagnostic tests at home over the last few months. We could roll that out for things like urinary tract infections that we know cause so many GP appointments each year. There's big potential here, but we need to operate at a certain scale. And sadly, a single-handed GP, maybe operating with a list of 4,000 people, is not attractive enough a partner for many companies who have innovative propositions.
Under the current structure, a lot of GP surgeries are owned by the partners. What's your how does one deal with that? How are you proposing to deal with that if you have more employed GPs?
So on premises, there's a big problem at the moment, and it's like an iceberg because you hear occasional stories of practices closing, but there's a lot of other practices where the current GPs are nearing retirement age. They might own that building. Roughly 50% of all GP surgeries are owner-occupied. And those people will eventually look to retire, and they'll want to pass on ownership for that building to someone coming through. But as I've already said, there's not that many new partners. People don't want to become a partner. So we've suggested that the state steps in and it offers to gradually buy up the owner-occupier estate. It's obviously got the balance sheet to do that. We estimate that will cost up to 5 billion. And then the state has a decision on when they want to convert that building into a different type of healthcare facility, whether they want to enhance it so it's an even better GP surgery, or they could choose to release it back to the open market. So, I'm sure many people listening will have visited a GP surgery in a terrace street. You could convert that back into a regular home because those buildings aren't really optimally designed to be healthcare facilities.
And Sean, one of the proposals of your report is that British qualified GPs, who are overseas, could still practice in Britain remotely. What would that open much more availability of doctors? What would the impact of that policy be?
Well, we think it's a great untapped opportunity for the UK to be a first mover in legislating for this type of change and sort of driving a new sort of global standard in terms of remote care across borders. So we know, for instance, that between 800 and 1,000 GPs that have trained in the system here have moved abroad to Australia, New Zealand, Canada, where they perhaps see the work-life balance being more attractive. And we're saying for people who have met the high standards required to practice in this country, that there's a possibility in order to deliver sessions within the English NHS, which we think could assist, for instance, in enabling the type of 24/7 care we'd like to deliver, because obviously if you're practicing in Australia, then you could deliver sessions during the day there, during the night here. So there's an opportunity there, but also in terms of people that then want to come back into working in the NHS. At the moment, there's quite a complicated, cumbersome revalidation process that takes place. And we think actually that delivering sessions remotely could be part of that assessment to enable you to more easily transition back to working in the NHS. So we think it's a big opportunity for us to leverage the possibilities of strengthening that close cooperation that we have between countries where already there's quite close sort of standards in terms of the training and medical qualifications that are required. So places like Australia, New Zealand, Canada, South Africa, these are the places where we think there's opportunity.
And who would be employing the New Zealand GP? They'd directly be working for the NHS, or you'd be subcontracting that to companies? So
within our model, they would be employed by the scaled provider. So this would be either a group of GP practices working together as a scale provider commissioned by the Integrated Care Board. So this is a board that's going to sit at a regional level. This has been placed on a statutory footing through the Health and Care Bill that's going through the House of Lords at the moment. So we would see them being employed by that provider at a scaled level. So that could be either a scaled digital healthcare provider, of which there are many reaching high standards. So that's where we'd see them being employed by.
Okay. Your report also proposes that something called NHS Gateway, which will be a new way for patients to interact with GPs, both via bookings and other services. And you want to encourage people, instead of having to wait on the phone to book GP appointments, to go via this new app, NHS Gateway website to book appointments. The NHS has got a terrible record, indeed government as a whole, in rolling out IT projects. Why do you think this won't sort of overrun and be delayed and cost billions more than you think it will?
It's a good question. We've tried to assess the opportunity for digital healthcare and then what we think the government can do in order to really tackle this issue of digital transformation, as it's called, which is an umbrella term. It encompasses everything from health data to the IT systems that the NHS uses through to app solutions, the types of innovative digital healthcare that's out there. So it's a lot of things, and part of that I think has been the reason why it's been so difficult to develop. Within that question as well, there's been the issue when it comes to the IT systems that the NHS uses. That's been procured at either a hospital level or within individual GP practices. So actually joining those systems up to deliver integrated care is very difficult. So this is part of the challenge, is that we're almost having to re-engineer, rewire the system. So that's the reason why it's been a challenge. But I'm optimistic about this because the Secretary of State has made it a real priority. The bringing together of NHS Digital and NHS X within NHS England to sort of enable this agenda to be streamlined. I think there's some real opportunity there. So optimistic on those terms. In terms of NHS Gateway, It seeks to solve a problem, but also to realise the potential that's not really being tapped into digital healthcare in particular. So what NHS Gateway seeks to do is it seeks to unify existing entry points into primary care. So at the moment, as Rob was talking about earlier, 85% of GP appointments are booked via telephone. We're all familiar with this situation. It's ringing up the GP practice at 8 a.m. in the morning, hoping that you'll get through and then triage to get an appointment when you ideally would like it. And people have become frustrated with this process because effectively demand has meant that a lot of people are not getting those appointments. So what we're saying is we think you can allocate resource more effectively by enabling people to use the NHS app, which we know that many more people are using now. Now 24 million people are downloading and using the NHS app. The Secretary of State wants at least 50% of adults to be using this in the next couple of years. So it's thinking about how you can use that tool, which a lot of people are using, to more effectively enable people to book appointments. But then we want to go much further with that as well, and to enable people, for instance, to be able to manage appointments across primary care. So I mean, again, Rob was using the example earlier. If for instance, it makes sense for you to book a home kit, a blood test, then that's something you should be able to do through the app, not necessarily going through general practice to begin with. So it's trying to think about the possibilities that are enabled by using that type of solution. But crucially, and I must say this because I think it's one of these things sometimes when someone flashes something digital in front of you, we don't in any way want to stop people or dissuade people from thinking they will get a reduced service if they want to maintain using the telephone, for instance, or that's their preferred option.
You keep the current options open.
Absolutely, we keep that open, but we're saying there's a great opportunity here that we should leverage.
Yeah. Question for both of you. Obviously, this isn't a party political proposal. You're putting forward an idea of how to reorganise the NHS, whoever's in power could adopt. But we've currently got a Conservative government, and the Conservative parties had the NHS is one of the weakest areas for them politically among public perception. And NHS reorganisations haven't generally fed well. They've fed into the narrative the Tories are privatising the NHS or reforming it or making it less free at the point of delivery. If you were a Conservative Secretary of State, why adopt a radical overhaul of the system now? Isn't that just opening you up to attack, saying that you're privatising by the back door, or whatever the attack line from Labour would be?
Well, it's interesting, Michael, because you said earlier, is this not nationalising of general practice? And so I think we'll get criticisms possibly on the report from two different directions. Some will look at it and say this is a nationalising, this is a lurch to the left. Others will say this is opening the market for more private providers to come in. And I think that probably is a signal that we've got it just right. The Conservative government at the moment is spending far too much money giving it to secondary and tertiary hospitals. Too much of the spend within the NHS is concentrated there. We've suggested that you have a significant increase in the primary care budget so that you can start to intervene with people before they get unwell, or at least if they have a long-term condition, it's helping them manage their weight or their blood pressure. And we know that general practice is really good at doing those kind of things, and they should be trusted to do more. But at the moment, you've got a situation where 60% of the workforce is reporting some sort of burnout, and on top of that, they're asked to run a successful business. That does not feel sustainable to me.
So you're thinking reform is essential just to keep things going, for the public to continue to have a decent experience of GP care or to improve primary health care. We need reform.
And I think this is the moment to do it. And I think you'll hear that from the Secretary of State in due course. There is the last 2 years have really presented the problems and flaws in our health service. And if we are going to sort of capture the public's attention and willingness to try new things, we've got to do it now. Sean was absolutely right when he highlighted the NHS app. We've all had to use it to access our COVID passes, to go on holiday, to get access to a venue. We need to make the most of that. Otherwise, it will just sit in people's phones now that we've got rid of COVID restrictions, and it will never be used. That would be a big opportunity wasted.
And Sean, where do you think resistance from your reform ideas will come from? What will people object to? What objections will be raised to what you're proposing?
Well, I think there'll be GPs who've worked for many years with a model that they've got used to in a premises that they're used to, and say, why now? As I say, And they'll say, well, this is worked for me throughout my career. What's the reason for changing things? But I think it's a recognition of looking at the emerging workforce, so junior doctors, but also those that are traditionally would be on the route to partnership, but are salaried at the moment or working as locum doctors, and what their desires are as a general practitioner, what it is about them that they want to be doing as a GP. And we tried to respond to that and to design and think about what the model is that's going to best suit them, and ultimately grounding it in what we hear from patients, the type of service that they want to see, the type of access that they want. So that's the way that we've ultimately designed our proposal.
You also proposed that we need a new digital health and care bill. What would that achieve? Why do we need a new piece of legislation?
Well, we're going to be needing primary legislation anyway in order to merge NHS Digital with NHS England, for instance. So as part of the creation of the Transformation Directorate within NHS England that I was talking about previously. So we think there's a huge opportunity here to use legislation as a way to really think through the types of changes that can make a real difference, both to people working in the NHS, but also patients too. So for instance, on data, really making the most of that data for research purposes, both within the NHS and also its partners, so universities, so the UK can continue to be a real leader when it comes to clinical research. And also giving much more power to patients to be able to choose how their data is used. So at the moment, hardly anybody looks at that or even has access to their patient record. We say people should be able to see that. If they want, their next of kin should be able to see it. They should be able to amend particular parts of it. And we detail areas in the patient record where you can do this. And there's a huge opportunity as well for clinicians to assist in delivering the type of continuity of care that we think is so fundamental to general practice and we want to see, by making sure small things like that they can include notes about things that their patients are interested in, and then every single person that then sees that record is able to engage with that and use that as part of that collected single version of the truth and experience. But the other thing as well that I think is critical here is it is also about really stimulating innovation and making the NHS an environment where if you are you've got a really exciting digital healthcare solution, it's the NHS where you want to try and scale that solution. So it's part of this is also really thinking about how to streamline both regulation and reimbursement. So it's a really high regulatory standard, and that we're on top of it, but also that we're looking at these questions through the lens of digital healthcare rather than trying to sort of shoehorn it into existing structures. And we think legislation can assist with that.
Whenever the issue of data is raised, people always have privacy concerns.
Yes.
But you're saying that with your proposal, you actually believe that you're giving more control to the individual over their own data rather than having their data sold off to whatever American pharmaceuticals, which might be the sort of scare story. You think this model actually increases individuals' control over how their data will be used?
If you look at best practice around the world, where you're able to create the type of conditions where there is that real transparency and you build trust, actually people do share their data. To use an example, in Estonia, since about 2008, they've had shared care records, and patients have the options to switch elements of their record on or off. They can see, for instance, which clinician and when their record has been accessed, and as a result of that, there is that openness and transparency. And as a result, hardly anybody in that system actually turns their record entirely off. That seems to me like the type of end state that we want to be reaching in the NHS. And what's quite interesting about the debate is I think people do have really legitimate concerns because of this sense that things have sort of been bulldozed or there's not been this transparency. But it's actually a relatively small number of people who really strongly believe actually that their data will be used for sort of nefarious reasons. I think most people recognise the opportunities that getting this right for clinical research, for actually more effectively planning services, really understanding demand patterns as well in general practice, which is something that's currently missing in the debate. It's about effectively, transparently talking about the opportunities and and having this open dialogue to make sure that people's concerns are met and are talked through, which is missing in debate. So we hope to stimulate that too.